Assalamualaikum everyone. Going to continue my presentation remaining from the ureterocolonic anastomosis. Different techniques of the ureterocolonic anastomosis, which include the Leadbetter and Claret, transcolonic technique of Goodwin, Strickler technique, and Pagano technique. Going to discuss one by one. Leadbetter and Claret technique. Basically, in this is the injection of submucosal tissue with a saline facilitate the dissection. A linear incision is made in the tinea and tinea is raised and the mucosa is identified. A small button of mucosa is removed and ureter is spatulated and then switched to the mucosa. It is a non-reflexing technique of the ureterocolonic anastomosis. Transcolonic technique of Goodwin. In this, the bowel is open on its anterior surface. A small rent in the mucosa is made. The mucosa is raised from the submucosa extending laterally. A 3 to 4 centimeter tunnel is made before the clamp exits the serosal wall. The ureter is grasped and pulled into the submucosal tunnel. Both ureters are drawn into the bowel through the submucosal tunnel before the each is spatulated and circumferentially switched to the mucosa.
Why the tunnel is formed in this?
To prevent the reflux, basically.
Main problem in these conduits and all the conduits and these kidneys reflux, and reflux itself is not a problem. If it becomes infected and the infected urine goes up, so it damages the thing. So anti-reflux, that is why these all techniques have been invented. Otherwise conduit was a very simple thing, but these were invented because of anti-reflex mechanism. If you people have any query, you can ask. Ji.
I just wanted to confirm that in pediatric age group we are very much concerned with the reflux. We should do anti-reflux, these sort of anastomosis. In adults, do we think the same way, or we can do non-refluxing in our cases?
Ideally, it should be non-refluxing, but in a pediatric population and adult population, there is difference that in an adult who can understand, you can explain him that you don't have to fill your bladder. If you feel like passing urine, you should go and pass it and all. In pediatric group, you cannot counsel them properly. So, and they have got a very long lifespan. So that is why these things are different. Ideally, it should be done like that. When I asked Mr. Philip Rensley about the same question you asked me, he said that ideally it should be like that. He was doing a trans interregic reimplant bilateral. What is that called?
Cohen's
Reimplant bilateral. He was doing it, and he replied the same way that these are the two differences by which we should be doing it. Ideally, when we get our patients, they are very complicated cases, previously operated, difficult dissection, in reimplants especially. While we are doing radical cystectomy and you are planning to perform, we have made few pouches, and the main concern about the pouch was that if the disease is free or not. That was the main concern. The pouch is working properly, there is no problem. Have you done a good radical cystectomy and have you chosen a good case that the margins are clear, everything is clear, that you don't have to radiate it? That pouch should not be coming in between the radiation or anything. That will damage it. Otherwise, we have made pouches and they are working very well. And they are non-refluxing as well. We make a tunnel and we place it like this. So depends on patient to patient and what you can offer them. There's a patient which came to our clinic last Tuesday, and very educated person, and he said, I want a cystectomy and I want a new bladder. He came from Shaukat Khana, referred from there, and he said, I want to get a new bladder formation. I said, he asked me that you people are specialized in it, and we make it, but depending on the patient's condition, that is his prostate normal, urethra normal, bladder base biopsy is normal, and his status is normal. You have to consider a lot of things and then decide, rather than upfront, yes, we can make it. So it varies patient to patient. But if you still ask me that after radical cystectomy, what should be the ideal thing? Most of the people, they are making island conduits worldwide. And new bladder can be offered to young patients who have got a long lifespan, and it has got its own problems.
The next technique is the stracular technique. A small linear incision is made in the tinea and the submucosa is dissected from the mucosa laterally. After the distance of 3 to 4 cm has been achieved, a small hole is made in the serosa and the ureter is drawn through it. It is also again the non-reflexing technique. A button of mucosa is excised and the ureter is spatulated and sutured to the mucosa. The rent in the tinea is closed with the interrupted sutures. Pagano technique. A linear incision is made in the tinea between the 4 to 5 cm in the length. The submucosa is dissected from the mucosa laterally on the both sides at the level of the mesentery. The ureters are drawn into the submucosal tunnel distally and sutured to the mucosa. The serosa is reapproximated with incorporation of the mucosa in the midline. Principle of the bowel anastomosis. It should be adequate exposure, ensure good blood supply of the bowel segment, control the spillage, accurate apposition of the serosa to serosa, ensure the tight anastomosis without the leaking of the bowel content, realignment of the mesentery to prevent the gut herniation. Principle of the ureterointestinal anastomosis. It could be the reflexing or non-reflexing. Still is on the debate that which technique should be preferred. Only needed ureter should be mobilized. Should not strip the periadventitial tissue because of the ureteric blood supply. Bowel should be brought to the ureter, not the vice versa. Watertight anastomosis, mucosa to mucosa done. Anastomosis should be retroperitonealized. Soft silicate stent can be used to avoid the stricture at the anastomosis side. Stoma principle. The side of stoma should be selected preoperatively. Marking of the side is made in the sitting and supine position over the rectus muscle 5 cm away from the incision. Away from the skin creases, scar, umbilicus, belt and bony prominence of the area had the radiotherapy. There are the two types of the stoma, flesh and protruded. Flesh is used when there is a method of the continent diversion, and protruded when it is selected when stoma device is applied to over it.
Internationally, there are stoma clinics. Unfortunately, we don't have. There are stoma nurses. This is a specialized field and it needs care. When we make a stoma, we have to plan and place a bag over it, and pre-operatively you have to mark it that where you have to make a stoma and all. We don't do that, but ideally it should be done because this will change a patient's life. And we take it very easily, but and another thing is that it should be pouting. If you are making an ileal conduit, it should be pouting. Why it should be pouting? When you make a ileostomy, you make a pouting ileostomy, and when you make a colostomy, you don't make a pouting. Why?
Contents of the gut.
If you people don't reply over here, you won't be replying in your exams as well. What will happen? You will say something wrong and few people will laugh, and they are laughing on themselves, not on you. So if you have got any query, you should ask. If anybody asks a question, you know the answer, you should reply. This laughing has got no value.
This is because in the pouting of a fecal will spillage out and it is more deleterious. Whereas if it is non-pouting, we make, then urine is not that detrimental.
Bola.
Sir, in ileostomy, we make pout because of the presence of many enzymes. There are many chances of excoriation. If we make and if we don't flush it out, then there will be excoriation. There more excoriation. I mean, in colostomy, we don't make such flushing stoma.
Why in conduits?
Same.
Because urine is coming out and it will cause excoriation as well and the problems as well. So you make a pouting. So the principle of pouting is that what our residents and doctors are not doing it. It should come out easily. That stoma should come out very easily outside that. People think that it should come very tightly, that it doesn't sink. That is the opposite. If it has to sink, it will sink. Okay, so clear that fat, open the sheet properly, take it out, take a stitch from the skin and then from the sheet and from the stoma it won't go back. I haven't seen that. But yes, I have seen black stomas and all because of that. The vascular supply gets compromised when you pull it out. You're pulling it out very weirdly. So the supply of that conduit should be okay. That is the main principle as well. That is why you have taken it on the supply. Ji.
Continent cutaneous urinary diversion. It should have the good capacity reservoir, low pressure storage, low metabolic issues, catheterizable efferent limb, continent mechanism, and a spherical reservoir having the low end filling pressure with the maximum radius. Indication for the continence cutaneous urinary diversion: external urethral sphincter sparing surgery is impossible, urethral malformation, spinal injury, or the complex neurological defect. Contraindication: impaired the renal and hepatic functions, patient with a neurological disease, mentally impaired patients, non-compliant patients. Types: rectal bladder urinary diversion had the different types: folded rectosigmoid bladder, augmented wall rectum, hemicock and teacock procedure, and sigma rectum pouch tube. Folded rectosigmoid bladder, it creates a folded rectosigmoid with the anastomosis of ureter via the serosal line tunnels rather than into the tinea cola to prevent the reflex again. It has a large sigmoid reservoir, prevention of the reflex by creating the serous line tunnel for the anastomosis. And patient will explain urine through the his anal opening. Augmented wall rectum. It is similar to the standard ureterosigmoidostomy, except that the proximal intersusception of the sigmoid colon confines the urine to the smaller surface area. Thus minimize the electrolyte imbalance. In addition, rectum page is attached with the ileum to improve the urodynamic properties of the rectum as a urinary diversion. Hemicock and teacock procedure, to be used as a rectal page when the ureters are too dilated to bring down between the leaves of intersuscepted sigmoid. This technique consists of the constriction of the hemicock or T-pouch employing doubly folded mud supplies ileum and the proximal continence mechanism to prevent the pouch ureter reflex. This pouch is then anastomosed to the rectum directly as a patch. This is the procedure. The 30 centimeter segment of the ileum is selected. The first 10 centimeter for the T implant and the distal 20 centimeter for the page. The 20 centimeter segment is folded in the U shape and open down as shown in the picture. The medial border are the closed with the running absorbable sutures. The ostium of the T is secured to the walls of the ileum with the interrupted absorbable suture. The wall of the ileum is closed over the T mechanism with the running absorbable sutures. The ureters are anastomosis to the top of T by the technique which we discussed. The T page is then secured to the 15 centimeter proctotomy with the 2 layers closure. Sigma rectum pouch, mains to pouch, it basically creates a low pressure rectosigmoid reservoir of the increased capacity. In this, patient is also worked through there is the anal opening. In this, the patient should have the continent anal sphincter. Continent catheterizable reservoir. Different types of this is scope pouch, double T pouch, mains 1 pouch, Indiana pouch, right colonic pouch with intersuscepted terminal ileum, mains pen pouch and gastric pouch. We basically have preferred the Indiana pouch and mains 1 pouch.
How to see the anal sphincter is competent? What is that test for the competence of anal sphincter?
Preoperatively, if we find the patient by history and examination doing the DRE, if the patient has a continent sphincter, but I don't know the test.
One test is there, it's a porridge test.
Sorry, sir?
Porridge test. So you have to push 200 or 300 cc normal saline in the rectum and ask patient that move here and there for 1 or 2 hours. And if he or she is continent, then the sphincter is competent. And then you can perform this mains 2 or ureterosigmoidostomy.
Thank you, sir. The cock pouch combined with a reasonably dependable technique for ensuring the urinary continence and preventing the reflex to the upper urinary tract. Nipple valve is used as a preventing the reflex with a carefully refashioned bowl that provides a low pressure urinary reservoir. This procedure is similarly constructed T pouch are only catheterizable continent diversion that preserve the ileocecal wall. The high complication rate and the technical difficulties involved with the constructing this reservoir mostly abandon this procedure. This is a diagrammatic picture of the coke pouch. Procedure is that the 15 centimeter segment of the terminal ileum is isolated and open along the antimesenteric wall. The proximal 10 centimeter will serve as the continent intersusception. The distal 5 to 10 centimeter as the page. The size of the page will vary according to the size of excised segment. The Ellis clamp is advanced into the terminus. The full thickness of the intersusception is grasped and is prolapsed into the pouch. 3 rows of the 4.8 mm staples are applied to the intersuscepted nipple valve using the TA55 staplers. The small buttonhole is made in the back of the ileal plate to allow for the stapler to pass through and advance into the nipple valve. A 4th row of the staples is applied, and the anvil of the staples can be dissected between the 2 leaves of the intersuscept, and the 4th row is applied in this manner. A 2.5 cm wide strip of the absorbable mesh is placed through the additional window of the davit at the base of each nipple wall. The mesh strips are fashioned into the collar. The collar is sent to the base of the pouch as well as to the ileal terminus with the seromuscular tissues. Basically, it is also used to prevent the reflex to the upper tract by constructing the nipple. Double T pouch. It is a novel continence mechanism created entirely from the ileum that created an extramural serosal tunnel into which the ureters are implanted. This extramural throw is created a pseudo tunnel that prevents the reflex. Direct transmural ureteral implantation can also be done to prevent the risk of the obstruction. 70 cm segment of the terminal ileum is isolated 50 to 20 cm from the ileocecal valve. A proximal 10 cm segment is isolated and rotated towards what will become the reservoir in the isoperistaltic direction. And the distal 12 to 15 cm is rotated towards the reservoir in the antiperistaltic direction. Sir, why we are taking one loop in the peristaltic direction and why this other in antiperistaltic?
Just the same reason that the continence, the reflex mechanism should be prevented. Sir, what is your take on it?
You anastomose both the ureters at the proximal 10 centimeter and continent mechanism through distal segment.
Yeah.
So idea is same. The peristalsis comes from ileum to cecum or colon. So when you place both the ureters at the proximal end, then there is peristalsis. There should not be reflux towards the kidneys. And when you take distal end for continent mechanism, and this is the vice versa. So you want to prevent the urine from bladder to the or pouch to the exterior. So that's why proximal segment is used for ureters and distal for continent mechanism.
A lot of people have come. We had a discussion that why we are discussing these so many types of conduits and reservoirs. The reason is that nobody was satisfied with the reflux mechanism, natural mechanism, and conduits which were continent and incontinent. So you have to think about everything, and we were discussing that a patient came and he said that I want to get a new bladder formed after radical cystectomy. So upfront you cannot say yes or no. You have to evaluate every patient. Every patient cannot be offered the same thing, and the main principles why we are discussing so many things are that which one is the best for that patient, which is anti-reflexing in long term. There can be tumors, there can be stone formation, there can be multiple things going on, metabolic problems as well. So we have to take everything in consideration and then offer that patient what treatment should be given.
And by this technique, you can avoid the obstruction as well, because the debate is for refluxing and anti-refluxing, that when there is obstruction, then it is more deteriorating than reflux. So reflux is preferable than obstruction. But if you can provide both the things, no reflux and no obstruction, then this is the modification by Ghunem. So the ureters are anastomosed with the proximal limb by Wallace technique. So there are less chances of obstruction and very less chances of reflux. So you can achieve both the things. because in continent pouches there is stasis of urine for 4 hours maybe, because they used to empty it after 4 hours. So there is lots of infection in that pouch and bacteria. So if there is reflux, then it's also deteriorating to upper tract, and obstruction is as well. So Gunem modified this technique by doing this, and you can also perform the orthotopic bladder by this technique as well. So this is the modification by Gunem of Mansoura.
So ideally, one should ace one technique. They should pick it up, learn that technique, and once they know that technique, then they should read about it and think about doing other things. The sir has used the name. He was the master of radical cystectomies and diversions in Mansoura, Egypt. So he invented a few procedures as well. But as the time goes on, you ace one procedure and then you modify it according to the need of the patient.
The distal continence mechanism is longer than the proximal anti-reflex mechanism in this pouch. The proximal and distal mechanism are tapered with the metal gastrointestinal anastomosis stapler. The bowel is incised along its anti-mesenteric border where it overlies with the two T's. The distal T's are of the bowel is inside close to the approximated limbs of the reservoir. The ostia of the walls are secured to the bowel with the interrupted absorbable suture. The two flaps of the ileum are closed over the T's with the running absorbable suture. The back of the reservoir wall is closed with a running absorbable suture, and the lateral walls are folded medially and construction completed with a running absorbable suture. Mains 1 pouch. The catheter-divisible main pouch varies somewhat from the orthotopic voiding main pouch. A longer bowel segment is used in main 1 pouch. The entire colon and the distal ileal segment are spatulated, taking care of preserved ileocecal wall. A 10 to 15 cm portion of the cecum and ascending colon is isolated along with the two separate equal sized limb of the distal ileum and the additional portion of the ileum nearing the 20 cm. A portion of the intact proximal ileal terminus is freed of its mesentery for the distance of 6 to 8 cm. The intact ileum is intercepted and the 2 rows of the staples are taking on the interception. The interception is lead through the intact ileocecal wall, and the third row of the staples is taken to stabilize the nipple valve to the ileocecal valve. The fourth row of the staples is taken inferiorly, securing the inner leaf of the interception to the ileal wall. A button of the skin is removed from the depth of the umbilical funnel, and the ileal terminus is directed through this buttonhole. Excess ileal is resected and ileum is sutured to the depth of the umbilical funnel, and patient is going to work through that funnel. Indiana pouch. In this technique, buttressed ileocecal valve used as a dependable continence mechanism that can withstand with the trauma of intermittent catheterization. This operation is involved the partial spatulation of the cecal segment and the attached ileal page. This represented major contribution to the original ileocecal reservoir in which the intact bowel reservoir was employed, and no attempt was made to strengthen the ileocecal valve. Segment of the terminal ileum approximately 10 cm in length along with the entire colon is isolated. Appendectomy is performed and appendiceal fat pad obscuring the inferior margin of the ileocecal junction is removed by the cautery. The entire right colon is open along its anti-mesenteric border. Interrupted Lambert sutures are taken over the short distance 3 to 4 cm in the 2 rows of the double imbrication of the ileocecal valve. Application of the opposing Lambert suture on each side of the terminal ileum. Excess ileum can be tapered by the stapling technique.
These Lambert sutures are the, you mentioned that buttress ileocecal valve. So these Lambert sutures are for the meaning for buttress is these Lambert sutures. They prevent the leakage of the urine. So these 4-5 stitches are very important. You have to not take the ileocecal valve in these sutures. Only cecum and ileum are used for that, these Lambert sutures, so that valve should not be affected, because sometimes we use staples as well. So when you use staples, then valve is excised or cut. So do not involve valve, only cecum and part of ileum is involved in these Lambert sutures. So this is the buttressing of the ileocecal valve.
Continent mechanism. Sphincteric compression. Narrowing of the afferent lip increase the resistance to the urinary leakage constructed by the plicating, tapering or intercepting the limb of the bowel. Peristalsis. When the ileum is used as an afferent limb preceding the peristalsis of ileum to that the colon serve as a counteractive forces to overcome the leakage. Nipple valve. Invagination of the afferent limb into the pouch result in the nipple valve. Equivalent pressure inside the reservoir will be reflected on the outlet to prevent the leakage. Flap wall. The construction of the part of afferent limb within the reservoir against the fixed wall, so that the intraluminal pressure of the pouch would cause the compression onto the afferent limb during the fling phase. In situ ileocecal valve used as a continent mechanism in the reservoir formed by the cecum. A short segment of the terminal ileum is used as a catheterizable channel. Orthotopic urinary bladder. It most closely resembled the original bladder in the both location and the function. The orthotopic new bladder allows for the violation of the voiding, avoids the need for the appliance, and only requires a self-catheterization in the minority of the patient. Three basic principles of the orthotopic bladder is the patient must have the adequate external sphincter mechanism and non-obstructed urethra. The reservoir must sufficiently compliant to maintain a low pressure throughout the filling phase, and it is achieved by completely detribulizing bowel segment and reconstructed into the spherical shape. The reservoir must have adequate volume to allow for the reasonable voiding intervals. This should be at least 300 to 500 ml once the pouch is mature. All patients who undergo the radical cystectomy may be considered at least potential candidates for the orthotopic urinary diversion. Number of the factors should be considered in the counseling the individual patient as the best diversion for the him or her. These factors can be divided into the cancer-related factors and the patient-related factors. This is an algorithm for the patient selection for the orthotopic bladder. If the GFR is greater than the 40, we will offer patient the orthotopic, and if it is not, then do not offer the orthotopic diversion. Intact functional external sphincter, adequate available bowel, very frail or the severe liver, cardiac or psychological disease is present, then we will not offer to the patient for the orthotopic urinary bladder. Cancer at the distal prostatic urethra, if it is present, then we not offer to the orthotopic urinary diversion. And the patient are willing and able to learn the self-catheterization, as some patient may require for it. Oncological factor. Primary oncological contraindication for the orthotopic diversion is the presence of urethral carcinoma at the urethral margin on the intraoperative frozen section at the time of cystectomy. Counsel the patient with a documented prostatic mucosal, ductal or the stromal invasion about the increased risk of the urethral recurrence if the urethra is left in situ. Risk of urethral recurrence in the women. In the past, urethrectomy was routinely performed at the time of the radical cystectomy. It has been believed that the bladder neck was a primary continence mechanism in the women, but initial clinical experience proved that one could achieve excellent continence by the dividing the urethra distal to the bladder neck. Risk factor for the urethral involvement included increased grade, stage, lymph node involvement, but the presence of the carcinoma in situ did not predict the urethral involvement. Vaginal wall involvement will also a major risk factor for the urethral involvement. Locally advanced tumor stage. Many urologists are hesitant to perform the continent orthotopic diversion in the patient with a locally extensive disease. This is based on the two factors: concern about the possible impact of loco-regional recurrence on the new bladder itself, and believe that these patients are doomed to suffer distant recurrence and have the shortened life expectancy and will not be benefit from the new bladder. If local tumor recur does help develop in the patient with orthotopic diversion, only minority will develop the problems related to the urinary diversion itself. Most patients could anticipate the normal new bladder function even in the presence of the locally recurrent disease. Patient-related factors. Age, chronological age alone is not the contraindication to the patient until and unless patient with the multiple comorbidities. One most important contraindication for the continent new bladder reconstruction is the compromised renal function. As we use the large portion of the bowel segment, it will increase the deterioration of the electrolyte imbalance. Obesity is also not a contraindication for the orthotopic new bladder, but the placing of the urethral suture and working with the thick bowel mesentery may be the challenging. Patient willing to do the self-catheterization and manual dexterity. Urethral stenosis disease are the external sphincter damage, prior pelvic radiation, prior prostatic surgery or the bowel surgery. There will be the small amount of the gut to reconstruct the orthotopic bladder.
And we have to select the patients who have got a clear disease which is confined to the bladder as well, because later we discussed with Dr. Asad that these patients, if they have got positive margins, they will be needing radiation later. And we formed a few pouches, catheterable pouches, and one or two patients out of them had an extensive disease and later needed radiation. So we need to evaluate pre-operatively that that pouch is not coming into the line of that bladder radiation, that when you radiate, that will cause the problem for that catheterizable pouch. Same goes for this as well. If later you have to radiate or any problem occurs, then there can be strictures, other problems for the that bladder as well. Sir, anything you would like to?
Surgical techniques for the continence preservation during the radical cystectomy. Anterior apical dissection in the male patient. Attention to the anatomical and surgical detail is important to optimize the functional and the clinical outcome in the patient undergoing the orthotopic diversion. Minimal manipulation of the muscle fibers of the rhabdosphincter, facial attachment, and the corresponding intervention is essential to providing the optimal urinary diversion. If nerve sparing approach is planned, the urethra may be divided after the lateral pedicles are taken down to the bladder, anterior branch of the internal iliac vessel, before the posterior dissection is performed. The prostate is then dissected in the retrograde fashion of the rectum, and the bilateral neurovascular bundle and the posterior pedicles are divided first. Care should be taken to avoid the deep suture bites into the complex or the levator muscle, which could ensure the continence mechanism. In the female patient, a standard female cystectomy includes the removal of the uterus, cervix, and the ovaries. Whether the uterus is removed or not, whenever possible, the bladder is dissected completely off the anterior vaginal wall rather than excising it. However, deeply invasive tumor on the posterior bladder or the trigone may necessitate the excision portion of the anterior vaginal wall. A patient with a significant tumor at the bladder neck or with the palpable extension into the vaginal wall is a poor candidate for the new bladder and should undergo the in-block urethrectomy and the cutaneous diversion. Preparation of female urethra for the orthotopic new bladder. The fatty tissue of the overlying anterior urethra is swept off the endopelvic fascia. The vesico-urethral junction is carefully identified by positioning the Foley's catheter at the bladder neck. Regardless of the form of vaginal reconstruction, a well-vascularized omental page pedicle graft should be placed between the reconstructed vagina and the new bladder to prevent the fistula formation. It secures the endopelvic fascia at either side of the urethral stem to separate the sutural line and prevent the fistula formation between the vagina and the urethral anastomosis, and to help to support the pouch posteriorly. The choice of the bowel segment. Excellent functional and the clinical outcomes with avoiding can be achieved regardless of the segment of the bowel chosen, as long as the principle of the preservation of the rhabdosphincter as a continence mechanism and the construction of the adequate capacity low pressure reservoir are maintained. Reservoir is made of detubularized ileum, or the ileum and colon together, are appeared to have the greatest compliance and the lowest likelihood of the generating intermittent high pressure contraction. The primary disadvantage of using the distal ileum lies in the potential loss of the absorption of the vitamin B12. Isolation of the segment bowel to be used for the diversion must be performed carefully to preserve the blood supply to the pouch as well as to the bowel anastomosis.
B12 deficiency कब हमें देखनी चाहिए? After
3 months.
At which post-op period we should see for vitamin B12
So
deficiency?
3 to 4 months.
3 to 5 years.
Patient has the reservoir with it.
Mostly occurs after 3 years of the
3 years.
3 years, yes. So there is storage in liver of vitamin B12. So patient used to use that, and after 3 years you have to then periodically check this vitamin B12. And before that, you should advise your patient that you take red meat, and so that exogenous requirement is fulfilled with that. But after 3 years, you should check the vitamin B12 periodically for these patients.
And that is why that 10 to 15 centimeter away from the ileocecal junction is being offered mostly.
Is the logic behind this to be create an internal fistula wire?
I read in literature that you should check B12 after 3 years because liver has got reserves of vitamin B12. So that's why, because I am the sufferer of deficiency of vitamin B12, my physician told me that it must be happening for longer time. It's not the acute problem with you. So, and I also read in literature that you should start doing vitamin B12 after 3 years of the continent pouches or where you are taking the ileocecal valve in your pouch. So I also will read it again. But
Anybody can have deficiency of B12. Maybe if few of us will go, we will be having it as well. But the main principle is that if you have good red meat intake, so it prevents it. That is the only, or you can take vitamins for that. So.
Need to prevent the reflex. When the orthotopic diversion, with the orthotopic diversion, most patients void by the Valsalva maneuver with the relaxation of the external sphincter. This resulting increase in the pressure in the reservoir should be transmitted equally to the rest of the system, limiting any resulting back pressure even without the anti-reflex mechanism. It is clear that any mechanism introduced to prevent the reflex may also potentially cause the upper trachea obstruction, which could be prevented. General perioperative management. Preoperative management of the patient undergoing the cystectomy and the orthotopic diversion is not significantly different for the patient undergoing other types of the diversion. Preoperatively, history should focus on the prior abdominal or the pelvic surgery or the radiation, current voiding pattern, and the continence. If the colon is used for the diversion, a colonoscopy is recommended to rule out the polyps or the tumor. Ileal reserve. Most ileal reserve used from the 60 to 75 cm of the terminal ileum, which is detabularized and folded into the variety of the ways to attempt create a spherical shape. Modification primarily include the variation in the exact folding technique and the variation in the management of the ureter with or without the anti-reflex mechanism. All reservoirs are closed with the continuous absorbable sutures to avoid the stone formation. The use of the non-absorbable suture and the metal staples should be avoided because of the potential for the stone formation. Two most popular configurations around the world are the Hartmann W bladder and its various modifications and the Studer pouch.
Before embarking on before embarking on using colon as a reservoir, but while we are using ileum, why we are not doing any endoscopic procedure?
There are more chances of problems in colon cancer as well as other problems. That is the reason. And it is quite difficult to go to the ileum as well to check it, and it's easy as a daycare procedure. You can perform a colonoscopy as well. Any other reasons, sir?
Some centers perform barium follow-through and barium enema studies few days before reconstruction. In those centers where I trained, gone for training, so they were performing oral water soluble contrast in their studies, and they were doing follow-throughs and barium enemas one day before the surgery. So few people are performing colonoscopies and some people are performing both follow-through and enemas to see ileum and also to see the large gut.
Another thing is that what happens, suppose you have open and you see a lot of roundworms in the ileum. I've seen when I was washed with somebody, but where I don't remember. When it was open, it was full of roundworms.
So what did that surgeon perform, madam?
I didn't remember, it's long back.
In that particular case, the case was abundant हो सकते हैं, and we go for deworm that patient हो सकते हैं, approximately 1.5 months later हो सकते हैं, we perform augmentation हो सकते हैं. Regarding your first question, in which for ileal segments हो सकते हैं, if the patient had abdominal TB, there are some centers or some few reports says that हो सकते हैं, they go for upper GI endoscopy plus biopsy as well.
We do a lot of augmentation, cystoplasty, not about I'm talking This is we are doing a lot of augmentation cystoplasty and GUTBs, and we don't know before opening what is the status of the intestine.
Madam, in particular case, I said in abdominal cox हो सकते हैं, we perform that हो सकते हैं, or few centers performs upper GI endoscopy plus ileal biopsies, but for GUTBs हो सकते हैं, it's not recommended. For go for upper GI endoscopy and get the biopsy.
Sir, have you got any experience that you opened the patient for any diversion or augmentation and you found worms over there? Then you had any experience?
In one or two cases, not worm, but in one or two cases we found lots of adhesions, and in one case we closed that case and gave her 3 months more, and then we again opened her and did cystoplasty. And one case few weeks back, it was operated. Laparotomies were done many a times because of RTAs, and so there were adhesions, lots of adhesions, but we had to call general surgical team for our assistance, and then we successfully did it. So in not so many cases we found these problems. One or two cases we have done maybe more than 400 cystoplasties. So Dr. Ruxana's question is why we do not assess pre-operatively in our cystoplasty cases, because it's not mentioned in books and literature, and second, we do not find any problem in our cases. So there will be one more investigation for that, because if patient has no complaint, GI complaint, abdomen is benign on examination, so I think there is no need of doing any study for ileum.
Madam, there is speed of time.
Chemi to orthotopic substitution is a modification of the original chemi bladder substitute, which was a simple segment of the ileum anastomos to the ureters and the urethra. The modification includes the detaperization and the folding to eliminate the peristaltic activity. The fingertip opening is made in the pre-selected area for the ileourethral anastomosis. The entire ileal plate is brought down to the pelvis and the urethral anastomosis is performed. The ileal loop is folded 3 times Z-shaped and inside on the anti-mesenteric border. The reservoir is closed with a running suture to approximate the incised ileum. The urethral anastomosis is performed and the ureters are implanted using the Leduc anti-reflex technique. Orthotopic cochlear reservoir, hemicoch. The cochlear reservoir was first used as a continent cutaneous ileal reservoir, incorporating intersuscepted nipple walls for the both afferent anti-reflex and the efferent continence limb. This subsequently evolved into the orthotopic form of diversion, in which the afferent intersuscepted limb was maintained to prevent the urinary reflex. The technical difficulty of the intersuscepted nipple wall and the associated complication, along with the development of the effective alternative techniques, has made this new bladder procedure less commonly used today. So go through the procedure. Total 61 cm of the terminal ileum is isolated. 222 cm segments are placed in the U configuration and open adjacent to the mesentery. The more proximal 70 cm segment of the ileum will be used to make the efferent intersuscepted nipple wall. The posterior wall of the reservoir is then formed by joining the medial portion of the U with the continuous running absorbable suture. A 5 to 7 cm anti-reflex valve is made by removing the mesentery under the segment and then intersuscepting the afferent limb with the use of Ellis forceps. The afferent limb is fixed with the 2 rows of the staples placed within the leaves of the valve. The valve is then fixed to the back of wall from the outside the reservoir with the additional surgical staples. After completion of the nipple wall, the reservoir is completed by folding the ileum on itself and closing it, leaving the most dependent end of the suture line open for the urethral anastomosis. Serous lined extramural tunnel. It is an effective anti-reflex mechanism by bringing the ureter into the reservoir through the extramural serosal line tunnel. It has several advantages. The serous line tunnel protects the implanted portion of the ureter from the exposure to the urine, so that the healing without scarring is ensured. Relatively, a short segment of the bowel is used. The procedure is versatile and not technically difficult. A 40 centimeter segment of the ileum is isolated and fashioned in the W configuration. The ileum is open along the anti-mesenteric border for the entire length. The inside mucosa is joined in the midline with the running suture. The two lateral flaps are joined by the seromuscular continuous suture to make baking the serous line urethral tunnel. The spatulated ureters are laid into the each trough, anastomosis to the intestinal mucosa and stent. The tunnel is then closed over the implanted ureter. The anterior wall of the reservoir is formed by folding the ileum side to side. The reservoir is then anastomosed to the urethra. Ileal new bladder Hartmann pouch. This is the new bladder of the large capacity spherical W configuration of the ileal reservoir that is constructed in attempt to optimize the initial volume and potentially reduce the nighttime incontinency. This pouch has a larger capacity than the Studer pouch, which may result in the early continency. It may also result in increased incidence of the late urinary retention and increased electrolyte reabsorption from the pouch. A 70 cm portion of the terminal ileum is selected. The isolated segment is incised on the anti-mesenteric border, leaving approximately 5 cm on the each end intact. The ileum is arranged in the W configuration with the forelimbs and switched to the one another. After a buttonhole of the ileum is removed and on the anti-mesenteric dependent portion of the ileum, the urethral anastomosis is performed. The urethral anastomosis are performed by the direct implantation either end to side or directly to the open ends of the two segments. The ureter is stent and the reservoir is then closed in side to side manner. Studer pouch. This ileal bladder substitute use a long afferent isoprostylitic tubular ileal segment. It is believed that the long segment functionally prevents the vesico-ureteral reflex when the patient voids by the Valsalva maneuver. The advantages of this bladder substitute include the simplicity of the construction, lack of the requirement for the surgical staples, and ability to accommodate the short ureters. Designated segment of the terminal ileum for the construction of the orthotopic Studer pouch. The distal mesenteric division is made between the ileocolic and the terminal branches of the superior mesenteric arteries, which extend into the avascular plane of the mesentery. 222 cm lengths make the reservoir and the proximal 10 to 12 cm length of the afferent limb, which will use for the ureteral anastomosis. The proximal to this 5 cm segment of the small bowel is discarded to allow the mobility of the pouch and small bowel anastomosis. Avoid the deep incision into the mesentery at that location, which could compromise the vascular supply to the pouch. The 44 cm length is open along the medial mesentery. The two 22 cm segments are joined in the U shape, then enclosed in the opposite direction. A proximal 15 cm segment of the ileum is to form the afferent limb. Sewing each suture line with the running 3,0 polyglycol acid suture, starting at the apex and running upward to the afferent limb. The reservoir is then folding in half in opposite direction to which it was open. Construction of the anti-reflex T-pouch modification. The afferent limb segment is separated from the reservoir segment, but the end of the afferent limb is closed. The dotted line depicts the incision line on the 44 centimeter segment of the detuberized portion of the ileum. The two ends of the reservoir at the closed mesenteric windows are open between the vascular arcades adjacent to the serosa of the afferent limbs to allow for the suture. The serosa of the two limbs of the reservoir is brought together through the window with the interrupted 306 suture to fix the backing of the tunneled afferent limb. The multiple sutures are placed through each window to secure the fixation while maintaining the good blood supply to the afferent limb. The afferent limb is fixed in a place. The incision of the bowel provides the wide flap of the ileum that covers the tapered distal afferent ileal segment to form the anti-reflex mechanism in a flap wall technique. A mucosa to mucosa anastomosis is performed between the ostium of the afferent segment and the edge of the ileal flap. The mucosal edge of the ileal flaps are brought over the tapered distal portion of the afferent ileal segment and sewn using the 3-0 suture. The opening is matured into the reservoir. The reservoir is folded in the half. The anterior wall is closed with the two layered 3-0 running sutures. The finger breadth opening can be left in the most dependent end of the suture line for the urethral anastomosis. Conversely, a new buttonhole can be created at the most dependent portion of the pouch for the catheterization for the voiding purpose. Each ureter is spatulated and a standard bilateral end-to-side ureteroileal anastomosis is performed using the interrupted 4-0 polyglycol acid suture. The reservoir is anastomosed to the urethra using the previously placed urethral suture. colonic and ileocolic pouches. Orthotopic men's pouch, men 2. Men 1 pouch which use the large bowel and the small bowel combinedly. Currently, it is not possible to recommend a particular type of urinary diversion. However, the most institutions prefer the ileal orthotopic new bladder and ileal conduit based on the clinical experience. In selected patients, such as the patient with a single kidney, ureterocutaneostomy is surgically the least burdensome type of the diversion. Problems with orthotopic bladder: stone, difficulty in the catheterization, parastromal hernia, and advantages over the ileal conduit. Early and late complication. Early complication is related to the surgery, not the particular type of the diversion. Is the bleeding, thrombotic event, infection, cardiovascular, pulmonary complication. Late complication could be influenced by the tumor recurrence and the use of the adjuvant and the salvage systemic chemotherapy or the radiation. Primary late complication of the orthotopic diversion that is directly related to the diversion itself is incontinency, urinary tract infection, ureteroileal and the afferent limb obstruction, upper tract and pouch stone, vaginal fistula and pouch rupture, and the urethral stricture. Post-operative cares vary depending on the method of diversion, early mobilization, intermittent compression stocking, serum electrolyte and creatinine monitoring. If you are using the single J stent, it should be removed on the day 5. If double J stent are placed, then it should be removed up to the 2 to 3 weeks. Regular irrigation and wash of the reservoir to prevent the mucus accumulation. Upper urinary tract surveillance for the hydronephrosis should be performed on the regular basis using the ultrasound or the CT scan.
So I guess we should conclude it. Excellent presentation. Thanks for elaborating all these procedures to us. A few were new. I also read them for the first time this time. And the main 2 orthotopic bladders are the Hotman and Studer. Studer has been successful because it is easy to make. And we have over here, I have assisted our professor in Hotman pouch as well and Studer as well. So they are doable things we can do, but the bottom line is every patient is a different patient, and you have to take in consideration a lot of things and then offer that patient what you can give to that patient in long term. And there is no ego in surgery. You open up the patient and you plan a Studer pouch or anything, and you feel that per operatively there are problems. You cannot offer him a continent reservoir or pouch. Then you can offer him an incontinent, but whatever it is best for the patient. At times we open up the patient for ileal conduit and we land up in doing a ureterostomy to that patient in the best interest of the patient, that we cannot perform a radical surgery rather than a palliative surgery. So the basic principle is whatever is best for the patient, it will change the life of the patient, and you have to offer that. If anybody has got any query, so any questions? Thanks. See you next time.